So we're going to talk about hypertension and what it is and what we as nurses have to monitor and look out for and teach our patients. I'm also going to, remember I posted that Jeopardy online as well. That is a great review of hypertension and kind of a fun way to deal with it. Okay, so what is hypertension? Well, hypertension is high blood pressure, right? It's usually defined as a blood pressure greater than 140/90. And remember, this is not just one reading. It has to be at least 2 consecutive readings at different times of the day. And sometimes what we'll do is we'll have a patient keep a log of blood pressures at home, have them take it different times of the day, bring that into their next appointment, and then we recheck the blood pressure in the clinic. But it is definitely across the board defined as a blood pressure greater than 140/90. Normal blood pressure is within the range of less than 120, less than 120/80. Now we do have a pre-hypertension state, I guess, and this is where we want to talk to the patient about, lifestyle changes and stuff. Once they hit stage 1, usually the physician's going to recommend treating that with usually one type of antihypertensive medication. Because what they're trying to do is keep tight control of that blood pressure to prevent any organ damage. Hypertension can be into primary or secondary. Now, secondary is usually related to something else that's going on in the body. We do know that about 30% of the adult population in the United States has hypertension. And approximately, they say about 54% of those patients that are diagnosed with hypertension don't have it under control. We do also know that certain ethnic populations have a higher tendency to develop it, and that would be like African Americans, Hispanics, the American Indian. They tend to have a higher proportion of diagnosis of hypertension in their genetic pool. Sometimes, it depends also because of their, the type of food they eat. That can play into it as well, and those things we can modify. So we'll work with them on that. Then, so what are the manifestations? What does the patient look like when they have hypertension? Well, it's called the silent killer because they really don't have any symptoms. But what happens is, as the blood pressure is elevated, it causes damage to organs. Because remember, as the blood pressure is elevated, it causes microvascular changes. Microvascular changes cause decrease in circulation, so then leads to damage to these major organs. The eyes are affected, kidneys, heart, and then also as well as vascular systems. So that's why increased stroke tendency, because they have issues with blood flow to the brain. So who is at risk to develop it? Well, genetics plays a big part of it, and that's not something we can change, right? So remember, we have modifiable risk factors and non-modifiable risk factors. So ones that we can't change our aging, we can't change who we were born, we can't change our family history, we can't change our gender, yes, okay, but we can't change the predisposing things that created us. And then also people that are higher risk are people that have developed gestational hypertension as well. What things can we educate our patient about changing? Well, they can lose weight. Obesity definitely increases your risk for developing hypertension. Sodium in the diet, lower it. We put them on a low sodium diet. Moderate alcohol use. We also want to increase their physical activity, and of course, we want them to stop smoking. And try to decrease stress in their lives. Sometimes that's a little hard, and I'm sure you guys can relate to that now in nursing school, right? You've got tests coming up and all, they'll definitely do it. So what kind of assessment do we do? Well, we want a good history and physical, right? We want to get, you want family history as well as you want to look, physical exam. Has there been any organ damage? You're looking into the eyes to see if there's any retinal damage. We're getting labs to check kidney function. EKG to look at the heart to see if there's any enlargement. They may do an echocardiogram as well. And then we get into management. What are we going to do for management? Well, lifestyle modifications are a big part of it. We want them to go on a diet, lose weight, which I know is tough to do, but it's very important. Increase their physical activity. The DASH diet, right? Low sodium, at least a 2-gram sodium diet. Sometimes they'll even lower it to 1 gram. Most likely they'll also low fat. Sodium's more related to hypertension, but they may also be on a low fat just because of their increased risk for cardiovascular disease. Like I said, we're going to increase their physical activity and we're going to cut down the alcohol consumption to a moderate. Medications. Well, what kind of medications are these patients on? Now, I know you guys have passed last semester several antihypertensive meds, right? And they all work a little differently, but the bottom line is they decrease the blood pressure. So we have to be careful when we give these, that we're monitoring the blood pressure before we give it and after. Because one, we want to see if the medication's working okay. And then the other thing is we want to check the response, because what if we're lowering the blood pressure too much? What's that going to do to our patients? They're going to be unstable on their feet, increased risk for falls. We want to make sure we look for that. Now, usually when someone is initially diagnosed with hypertension, they're going to start on monotherapy. So they're going to start one type of medication first, and then they're going to, if after monitoring the blood pressure still isn't within normal limits, then they might add a secondary medication. Most often they'll start off with like a thiazide diuretic. That's usually what they'll do. Remember, we have to watch electrolyte levels with that as well. Another common one that a lot of times they'll use is like a beta blocker. But remember, you have to watch out beta blockers for patients that have asthma. All right, so here's a question for you. I'll give you a few minutes to read it. All right, so in reviewing, for patients with uncomplicated hypertension and no specific indications for another medication, what is the initial medication they would start? And as I said earlier, it's going to be a thiazide diuretic. This is for someone who has uncomplicated hypertension, okay? If the blood pressure does not fall below the 140/90 mark, then they may increase the dose gradually. Remember, whenever they start a medication, they start at the lowest dose possible. We want to assess the patient's response. So think about it. First time in the hospital, someone's getting this medication. We check the blood pressure before, and then after we give it, they say, I got to get up and go to the bathroom. Do we want them to get up walking by themselves? No, because we want to make sure that they can get up and be steady on their feet, because we just gave them something that could potentially, as they stand up, drop their blood pressure. So very important that we check for that. All right, so like we mentioned, usually it's one drug, usually a thiazide diuretic is most common. And I mentioned the dosing, that it starts low and then we gradually increase it to get the blood pressure under control. You want the blood pressure to be as close to normal as possible. Then if that patient does not respond to that, then you may add additional medications. Some patients may require multiple medications. So when I'm caring for a patient in the hospital and I noticed they're on like 3 different antihypertensives. I'm like, wow. That means to me that their blood pressure has been out of control for a while. Maybe they didn't do lifestyle modifications. Maybe they just have really poor gene pool, and that's led to the risk. So I think it's really important that we look at that. The other thing is when I'm working in the outpatient area and I've started someone on a medication and then they come back in and their blood pressure is still the same or maybe it's quite elevated. I want to get more information from that patient. I want to ask them, when did you take your medication this morning? How often have you missed doses? Do you take it on a regular basis? Those kind of things. Because one, sometimes these meds cost a lot of money or these people don't have insurance, so we want to make sure that they can afford these medications. Because it does mean no good to write them a prescription, send them off on their merry way, and they don't take the medication. So first and foremost, I want to make sure that they understand that, have they taken the medication? And then and it's a great point for new re-educating them. This is something you have to take meds every day for. It's not like a infection where you take it for 10 days and you're done. They have to take it every day. The other thing, any time we have a point where we're, patients there, we're always talking about lifestyle changes. Talking to them about things they might incorporate into their diet to help with the blood pressure, as well as working on exercise, diet, and asking questions about the diet. If they tell you, oh, I have a glass of tomato juice every morning. Well, we know tomato juice is high in salt, so we might want to talk to them about alternatives, those kind of things. All right, so as far as me as the nurse, what do I want to look for? Well, I want to look at risk factors. What can I help this patient control? The next thing I want to look at is assess for potential symptoms. Remember I said how we want to watch for target organ damage. So these are the biggies: cardiac, heart, breathing issues. Think your ABCs, circulation, neuro. We're looking for all those things to make sure that this poor person isn't getting potential complications or collaborative problems, right? We want to check pulses. We're going to assess gait. We're going to ask them questions. Do they get up during the night to go to the bathroom? Have they noticed their vision change? Have they noticed increased frequency in nosebleeds? Those kind of things. The other thing I want to talk to them about is, remember I talked about the medications and having to take it every day. Well, if pharmacy bumps up the cost of the medications, maybe finances come into play here and they can't afford the meds. So maybe we have to look for maybe a cheaper alternative or a program that can help them pay for their medications. So communication is crucial with this because it's a chronic disease. All right, so now let's talk nursing diagnosis. I know it's like one of your favorite things in the world to talk about, but these are some potentials. Remember, this is deficient knowledge regarding the relation between the treatment regime and the control of the disease process. Lots of times patients think, especially say they came in and they weren't feeling well, they get put on the medications, they come into you 2 weeks later, their blood pressure is fine, they think, oh, all is good. I've been walking every day. I don't need this medicine anymore, and they just stop taking it. Well, we need to educate them and understand that this is not how it goes. But the same respect, if say they drop 10, 15 pounds, we definitely want to keep logs of that blood pressure because maybe they don't need that dose that they once were on, okay? So those kind of things we want to talk about. Always assessing for noncompliance, finding out why. A lot of these medications will have side effects. People don't like taking them. They don't make them feel well. So then we need to have that open communication with our patient to find out why they're not taking the medication and find out how we can help them with that. Now we talk about complications, and again, if you look at this list, it's all target organs again. These are potential things that can occur when you have hypertension. And this is why it's critical that we maintain tight control of that blood pressure. So look at that list. They're not very good things you want your patient to have, right? So we want to, these are the things, talking to the patient about. If you have chest pain, this is what you do. If you increase shortness of breath, your shoes get too tight. That could be an exacerbation of heart failure. You need to call the doctor. A weight gain, those kind of things. What are the stroke? They need to be educated on what the symptoms of a stroke is, right? And some of the symptoms can be pretty vague, so they have to be aware of those. I've taken care of patients where they've literally, it hasn't been, we talk about like weakness in the hands and stuff. It hasn't been any of that. It's been more of a blurring of the vision or inability to get the words out. So, it can be real vague. So they need to be aware of everything. So one of our, nursing process, and we talk about how we're going to deal with this, how are we going to plan, and what kind of goals are we going to set for our patients? Well, ideally, I want them to understand what's going on in their body, right? And then I want them to verbalize to me that they understand what the treatment is. Self-care programs. Yes, I want them involved. Maybe they're going to Weight Watchers. Maybe they join their gym, or they have a personal trainer now at the gym or something, or they're attending a class. All those are wonderful. And my ultimate goal is I don't want them to have any complications. I don't like it when my patients get complications. It can be sad, and I don't like that. I like my patients to do well. So how am I going to go about this? Well, this is a diagnosis just like, we've talked about diabetes before and heart failure earlier in the week. Hypertension is critical for education. And we need to support the patients through the process. And then the thing is, don't give the education once and be done. Constantly re-educate the patient. We may offer a consult. We may get a dietary consult for them. If they're really decompensated and having some heart issues, you might send them to cardiac rehab for a little bit. Those kind of things. You want to reinforce and support lifestyle changes. Kind of be their cheerleader, right? Involve the family or, significant other. Sometimes that will help them adhere. Maybe the whole family needs to be looked at. If dad's overweight, mom might be overweight, then leads to the kids being overweight. So how can we help that family through that process? So how do I know things have worked? And this is probably part of the care plan we tend to skirt over a little bit. But we want the patient to verbalize that they understand what's going on. That they understand that the reason why we want to maintain tight control of their blood pressure is we're trying to prevent organ damage. We want them adhering to the program, right? That's important. Recognizing what things in their diet has sodium in it. Excuse me. They've stopped smoking, right? Very important. The other thing we're going to have them do is report no additional symptoms, renal functions within normal limits, blood pressure is within normal limits. Okay, so what about the gerontological considerations? If the medication regime is complicated, so say they're taking one pill twice a day and one once a day, that can be a little confusing for some people or difficult to remember. So we definitely want to make sure they understand that, maybe setting up a pill box, something like that. Expense could be a challenge, especially if they have a fixed income. And we want to be open and ask those questions. We try to keep therapy as simple as possible. And then make sure that they understand that this is, again, something they have to take day in and day out. They can't just take it on Monday, Wednesday, and Friday and be good, okay? And then we want to include the family as well as any caretakers. If we happen to have issues with like beginning dementia or stuff, we definitely want the family members involved. All right, so here's another question for you. I'll give you a couple minutes to read it. All right, so what should be incorporated into the plan of care? Aerobic exercise, right? Brisk walking 30 minutes a day, most days of the week. Important. Remember, they can consume alcohol in moderation. Sodium should be reduced to no more than 100 per day. And the patient should maintain a BMI between 18.5 and 24.9. Okay, so let's talk about hypertensive crisis. There are actually two things, hypertensive crisis and hypertensive emergency. When these are both emergency situations, they both require intervention. If we're educating the patient at home, we are talking to them about if they experience a systolic blood pressure greater than 180 and it stays up there, they can cause a lot of damage to those target organs. So they would need to call 911 and be seen right away. And remember, they're kind of treated the same way, and we want to be careful not to decrease the blood pressure quickly. There are certain clinical situations that we would want to, like if there was an aortic dissection or a stroke, you want to bring it down quick. But gradually, it would be best to bring it down gradually. And the formula is usually you're reducing it about 25% in the first hour. It requires frequent monitoring. They're in critical care. They're on IV vasodilators, something like sodium nitroprusside or IV nitroglycerin. And you're constantly titrating those meds. And you'll do all this in critical care when you get there. But they are like blood pressure is Q15. You're constantly titrating the meds. You're constantly drawing labs to check, to make sure there's no organ damage. There's a lot going on. Obviously, they're on a heart monitor. And it's a one-on-one situation. Now, hypertensive urgency, yes, they still require close monitoring of blood pressure and their cardiovasculars. And the same goal, we're preventing issues with target organ damage. Because the blood pressure is shot up, it's going to cause more damage quicker. So we're going to put them on fast-acting oral agents, like a beta-adrenergic blocker, something like labetalol is a very common one. Captopril is another one, clonidine. All those can be used. All right, so here's another question for you guys. And remember, for both hypertensive crisis and hypertensive emergencies, lots of times they're going to be for crisis, they'll be in the ICU. For emergency, they could be on like a PCU type unit, depending on how the acuity is. So what is a priority nursing assessment when caring for a patient in hypertensive crisis receiving IV intravenous vasodilators? What do you think it is? Intake and output. And why do you think that? Why do you think that? Because if we say we're protecting target organs, right? So if we narrow it down, B and C deal with target organs, right? But which one, if we use our ABC, if you think about which one could cause the most damage, I guess. And we want intake and output because of fluid volume, right? And the risk for kidney damage. All right, that's the short and sweet bit about hypertension. Remember to look at the Jeopardy slides. I think you'll have fun with that, and that'll help. Um, and that's it.